Thank you for the opportunity to present at the Reagan-Udall COVID-19 Evidence Accelerator. I'm Patrick Ryan. I'm here to present on behalf of the OHDSI community. Amy Abernathy asked me to talk about the OHDSI COVID-19 Study-A-Thon event that took place a few weeks ago, as well as to highlight the results of our first study that we've released on the evaluation of the safety of hydroxychloroquine in rheumatoid arthritis patients. So for those of you who don't know, OHDSI is an open science community. We have a global collaboration of researchers around the world. There's many hundred researchers who are actively participating in research within the community, all working on a common mission, which is to improve health by empowering a community to collaboratively generate the evidence that promotes better health decisions and better care. In addition to being a collaboration of individuals, we also have a large data network. The OHDSI data network comprises over 150 databases in 18 countries, covering more than 600 million patient records. Now, what does it mean to be part of the OHDSI data network? That means that these are organizations who have access to patient-level data, who have adopted the Open Community Data Standard, which is known as the OMOP Common Data Model. So the prior presentation by Atul Butte that highlighted the work at the UC Health System reinforced their use of the OMOP Common Data Model, and Amy Justice's prior presentation at the VA highlighted work where the Department of Veterans Affairs is also using the OMOP Common Data Model across their national sources. We have data across the world that's using this data standard, and this makes it possible for us to do collaborative research across multiple data sources. Now, I was asked to talk about the OHDSI COVID-19 Study-A-Thon. This was an event that started on March 26th, and this was actually held in lieu of our European symposium that was supposed to be held during the same time. But instead, we held a virtual event where we invited any researchers around the world interested in collaborating on research associated with COVID-19 to come together for 4 days to work in a virtual environment to collaborate on how we could use observational data to answer important questions. If you're interested in learning more about this, everything that we did during this session was recorded, and there's been regular updates posted on our website at ohdsi.org/COVID-19 updates. So what I'd like to do briefly is just summarize for you, what did we do in this 4 days together? Well, first, we reached out to our colleagues at the FDA, EMA, CDC, and other public health agencies to try to understand what were the priority research questions that needed to be answered. And we classified those needs into 3 main areas. There's clinical characterization. Those are the questions of descriptive natural history of disease and treatment utilization. And we recognized that there was a clear need to understand patients who are being tested for COVID, those patients who are tested positive, those patients who are hospitalized, and what are the treatments and outcomes that are followed for those patients. We focused on questions of patient-level prediction, trying to understand how we could develop clinical decision support tools to help flatten the curve. So we focused on questions around amongst patients with symptoms, who are likely to be hospitalized, amongst those who are hospitalized, who are likely to require intensive services, and amongst those who require intensive services, who are those who are likely to die. And the last area, which Amy asked me to focus on, was population-level effect estimation. How could we use observational data to start to understand the safety and effectiveness of medical products, both by looking historically at how these drugs had been used for their originally intended indications, as well as to design studies that would allow us to explore these effects in a COVID-19 population. And as priorities there, we focused on understanding the effects of hydroxychloroquine, also looked at IL-6 and JAK inhibitors, looked at protease inhibitors for HIV and hepatitis C, and also tried to design a study that assessed the impact of ACE inhibitors and angiotensin receptor blockers in COVID. Now, for each of those, we recognize the way to do research is to go through a process of first doing a literature review to understand the context of what's known, to design a study and implement definitions that we could use in that analysis, to implement an analysis package that could execute the protocol as designed, to execute that analysis package across a distributed network of data partners, and then to collaboratively review the results. So this is where we started on March 26th, and this is where we ended up 88 hours later. We made tremendous progress across all of these different study questions in terms of designing, executing, implementing, and then starting to share results from this work. And I want to highlight this because I think the opportunity of working across a collaboration is to be able to take a large group of researchers and identify specific subgroups that can focus on particular areas, whether it be a particular clinical question represented by the rows here, or a specific technical competency represented by the columns here. And while we had 300 researchers come together as part of the Study-A-Thon, we're able to each focus on our key competencies to advance this collective mission together. So what happened during the OHDSI Study-A-Thon? Well, in 88 hours, we were able to convene over 300 researchers from 30 different countries. And together we used a virtual collaboration platform hosted by Erasmus MC. That was the Microsoft Teams environment that allowed us to hold asynchronous chat sessions, to hold teleconferences and video conferences, and to hold live events for all of the participants. During this time, we did a systematic literature review across these various topics. We drafted protocols. We developed analysis packages in open source software that could be run. We created phenotypes for all of the diseases, outcomes, and treatments of interest. And importantly, we assembled a data network of 37 data partners who were willing to execute studies. And again, these are data partners who have already converted their data to the OMOP Common Data Model and are interested in executing these study packages and sharing aggregate results as part of a distributed network. So what did we do during this Study-A-Thon that we think is worth highlighting for this group? Well, 3 areas that we focused on. The first is our first examination of characterizing COVID patients in a hospitalized setting across multiple institutions in the US and Asia. And this is a paper that we hope to post up on medRxiv in the coming day or two. The notable thing here, and to reinforce what Amy Abernethy mentioned before, we're seeing lots of papers come out about the experience of one institution, but we don't actually know whether those findings generalize to other settings. And so by examining and comparing multiple institutions at the same time, we can start to understand where there's consistency and where there's heterogeneity in the patient's experience. Second thing I'll highlight is our work in prediction, where we focused on developing and training models in a flu population and then externally validating that in a COVID population. And I think this is important because one of the things that we desperately need is lots of data on COVID patients. But of course, this is data that's accumulating. So if we can learn from historical data and then apply models to a current data, we can learn quite a lot. And then the last thing where I'll spend my last couple of minutes here is to talk about the largest ever study conducted on the safety of hydroxychloroquine. Here we were able to assemble a data network of 14 data partners that collectively comprised the patient experience of over 900,000 patients who were exposed to hydroxychloroquine. And we're able to use that historical data to understand the safety of that medicine in rheumatoid arthritis patients, hoping that that evidence might be useful in the context of its potential use for COVID-19. So I'll focus just a couple minutes to describe the process and the results of that hydroxychloroquine study. The first thing that I'll highlight is that doing open collaboration requires full transparency in every step of the research project. We shouldn't just be getting together to share results. We should actually be thinking about how we can collaborate on every step along the way. As part of this study, we wrote a protocol, we posted this and made it publicly available, and we registered that protocol in the NCEP Pass register. We've been designing phenotypes to identify patients who are exposed to hydroxychloroquine and the various adverse outcomes that we wanted to study. All of those phenotypes are available in both human readable and computer executable form using the Atlas tool that runs against the OMOP Common Data Model. As we developed this analysis package, we made all of the code freely available and directly downloadable through GitHub, and you can see the URL here. As we drafted the manuscript, we first posted this on medRxiv while we were awaiting peer review from a journal. So I want to thank Harlan and the medRxiv team for making that possible. And in conjunction with sharing the document, we also made all of the analysis results publicly available through an interactive R-Shiny application. And I share the public URL here. So as it relates to the results that we've been able to highlight, here's a screenshot of the medRxiv paper that's up on our preprint server. This paper focuses on examining the safety profile of hydroxychloroquine, both new users of hydroxychloroquine in an RA population, but also looking at concomitant use of hydroxychloroquine with azithromycin, trying to answer a few different questions as it relates to that. We conducted both propensity score adjusted new user cohort designs, as well as self-controlled case series designs to try to provide ourselves a rounded understanding of the safety profile of this medicine. So we examined 16 different adverse events that we may be concerned about associated with these products. We assembled a cohort of patients with rheumatoid arthritis who are over 18 who either initiated hydroxychloroquine or sulfasalazine. And we looked at the outcomes associated with short-term use, short-term effects within the first 30 days after initiation, as well as the effects while the patient continued to be exposed to the drugs. We also compared hydroxychloroquine and azithromycin versus hydroxychloroquine and amoxicillin as a comparison to try to understand effects there. We were able to execute this analysis across a range of 14 different databases, both claims and electronic health record data, in data from the United States, across Europe and Asia. And the manuscript that's up on medRxiv clearly describes the various statistical methods. Importantly, we ran this as a distributed data network where we were producing results for each data source by itself, but we pooled results where possible into a meta-analytic composite estimate. Figure 1 in our preprint server highlights some of the results. The key findings of this work is that based on the research that we were able to conduct, hydroxychloroquine appears as if it is safe in short-term use in rheumatoid arthritis, but long-term use may be associated with an increased cardiovascular mortality. Probably the larger effect that we observed, which is shown here in the second column of the results, however, is that when we looked at hydroxychloroquine in combination with azithromycin, we observed a twofold increased risk of cardiovascular mortality as compared to amoxicillin. And we also saw an increased risk associated with heart failure. These results are still under peer review, and so we should read them with some caution. However, on the basis of this, we've already seen Harlan and others using this preprint to at least start to shape the conversation that is going on about the potential safety of hydroxychloroquine. I do want to thank all of the over 300 researchers who got together as part of this Study-A-Thon and reinforce that while this Study-A-Thon was a great way of galvanizing a community to work together for a couple days, this journey of doing research on COVID started before the Study-A-Thon started, and it's continuing in earnest across this community of researchers. And as the Reagan-Udall Foundation thinks about this COVID Evidence Accelerator, I want to encourage anybody who's interested to join the journey to come join with us. The last thing I'll just highlight as we're talking about data elements is we're oftentimes talking about what data are needed for what questions. And as a framework that we've created in the OHDSI community to think about this, we want to recognize that different data sources are going to have different types of data. And rather than us looking to try to compile a network of everybody having full and complete data across all elements, instead we should think about what research questions can we answer given the data that's at our disposal. And what we've observed across the OHDSI data network is that there are different data available at different sites that allow us to answer different types of questions. And as a community, what we're going to be trying to do is move forward as many of these questions across as many data sources who have the necessary data elements required to answer those questions. We're happy to share this as a framework for this community to be thinking about as together we can collaborate on questions of interest. So with that, I'll stop. Thank you all for your energy and attention. I look forward to collaborating with you.